Dear colleagues, as we unfortunately had to cancel this year's World Congress in Montreal, we thought it would be a good idea to at least share some highlights from the virtual Congress that took place in February. Before the video starts, I would like to announce that the 2022 World Congress in Taipei, Taiwan will take place from June 9th to the 12th. I look forward to seeing you there in person, and now please enjoy the video. Oh, and don't forget to subscribe to our YouTube channel below for free so you can watch more videos in the next weeks. Thank you.
I'm Larry Klassen. I'm a psychiatrist based in Winkler, Manitoba, Canada. I'm the research chair there and have a keen interest in mood and anxiety disorders as well as adult ADHD. Today I'm going to be speaking about ADHD and comorbidities with treatment implications in that. So what I'm going to be trying to do over the next little while is give an overview of ADHD and psychiatric comorbidity and focusing on mood, anxiety, and substance use disorders primarily. Comorbidities can affect the treatment choice and outcome, and I like to emphasize a multimodal treatment being ideal. And finally, I want to go over the benefits of treating ADHD in the context of comorbidities. These are the data from the National Comorbidity Survey replication, and this is looking at people with ADHD. And as you can see, just in the 1 year previous to the time that this survey was done, almost 19% of people with ADHD had a major depressive disorder. Almost 20% had bipolar disorder, and this is just in the previous year. This isn't lifetime. Anxiety disorder, almost half of them, and dysthymia, about 13%. Now, what if you flip that and go the other direction? Say, if you have that comorbid condition, what's the likelihood you have ADHD? Well, the numbers are just as impressive. A person in your office that has depression, about 10% likelihood that they have ADHD. Bipolar is over 20%. That chronic dysthymic patient, over 20%. And again, anxiety disorder, someone presenting with anxiety, almost 10% have ADHD in the background as well. And yet it usually goes unrecognized. This is one of those reasons, because there's a lot of overlapping symptoms. For instance, you can see depression, there's some symptoms overlapping, conduct disorder, anxiety is overlapping with the restlessness, difficulty concentrating, decreased attention, swings, substance use a bit more, look at bipolar, right across the board. All those symptoms are fairly consistent. It's all about time and the course of the disorder. And we'll go over a bit of that in differentiating that. Shared features, again, remember that one slide showed right across the board, symptoms were very common and shared between these two disorders. Restlessness, talkativeness, distractibility, and fidgeting are common with both. But the difference is that depressed phase of bipolar disorder and the episodic nature of the symptoms. So what I tend to look for is changes in the affect, like incongruent with what's going on around them. Unfortunately, there's again a worse overall course of illness. There's shorter periods of wellness, and there's more frequent episodes of mania and depression when ADHD is present. It's also a higher rate of other comorbid conditions such as anxiety disorders or substance use. The use of stimulants in bipolar depression remains unresolved, but I'm going to show you a bit more recent data on that as well. The following are considerations for stimulant use in bipolar disorder, raising that hedonic tone in bipolar depression, advocated by some once mood is stabilized, but that's the key, is the mood needs to be stabilized. And there is some potential increased risk of stimulant-associated mania and hypomania, but that can be tempered when bipolar is treated appropriately. And here's what I mean by that. 2017, this study looking at Swedish national registries looked at 2,300 adults with bipolar disorder. And as I said, it remains controversial concerning precipitating mania. So they looked at what happens when bipolar patients are treated with methylphenidate. Those with concomitant mood stabilizing treatment, without concomitant mood stabilizing treatment, had an increased rate of manic episodes within 3 months, hazard ratio of 6.7, and Similar rate for subsequent 3 months, so up to 6 months out. But this is the important part, those with concomitant mood stabilizing treatment, risk of mania after starting NPH or methylphenidate was actually lower. The hazard ratio was 0.6. So treating the ADHD with a stimulant once a mood stabilizer is on board actually helps stabilize the bipolar condition as well and reduce the risk of mania. Let's look at substance use. ADHD is overrepresented in the substance abuse population. And here you can see, based on these data, patients with opiate dependency, 5 to 22% have ADHD, cocaine dependent 10 to 25. Look at the alcoholics, 33 to 71%. That's very high. And I always say that if a person has a substance use disorder, at least screen for ADHD, at least screen for some of the symptoms from childhood, screen for some of those difficulties now. I tend to go with PDF, procrastination, distractibility, forgetfulness. Those are 3 very quick and easy questions one can ask. And you can ask about it from childhood as well. Did they have some of those symptoms when they were a kid? Once again, in the ADHD population, there tends to be an earlier onset of substance use. There's a more severe course of substance use disorder. There's poor treatment adherence, and there's a higher rate of relapse, unfortunately. What kind of substances are we looking at? Well, you name it, and it can be a concern. People with ADHD will tend to smoke more, 3 times higher risk of smoking, and they tend to start smoking at an earlier age. Coffee and colas. I've had patients that would drink multiple pots of coffee, not cups, but pots of coffee a day. And when their ADHD was treated, they brought it down to a couple of cups, and it found it quite easy to do that. And of course, alcohol. As noted, there's a very high rate of ADHD in people with chronic alcoholism. How about the non-legal products? Well, in Canada, cannabis is a legal product now, but it's still probably the #1 that people are using in terms of drugs outside of alcohol. Cocaine and stimulants are fairly common, and hallucinogens. The point in the box is an important one. Treatment with psychostimulants does not increase the risk of drug dependence. In fact, treating ADHD could reduce the risk of substance abuse. And one might say, well, how can that be? Because ADHD stimulants can be drugs of abuse. And you're right. The immediate release and using them inappropriately, such as crushing them up and snorting them, which I've seen patients that have done that, that is a form of abuse for stimulants. However, using the long-acting and using them appropriately with the patient that wants to come off of substances is a more successful pathway. So this was something that interested us, my group, some colleagues and I. And so we looked this up, and the data come from Joe Biederman and his group in 2019, looking at treating ADHD and how it can prevent sequelae. They looked at number needed to treat. So how many patients with ADHD do you need to treat with a stimulant to prevent X? And that number needed to treat is very low for a number of things. It's as low as 3 for developing conduct disorder, anxiety disorder, ODD, or even repeating a grade. So treating 3 patients will help prevent 1 person from having to repeat a grade. Goes beyond that, developing major depressive disorder or having a major car accident. Number needed to treat is 4. Developing bipolar disorder, number needed to treat is 5. Smoking, 6. Developing a substance use disorder, 10. By comparison, you look on the other side here, number needed to treat with a statin to prevent a heart attack is 104. And antihypertensive to prevent a heart attack is 100. So these are beautiful numbers that we have in treating ADHD with comorbidities. Finally, I'm just going to summarize that comorbidity is the rule. It's not the exception, in adults especially. And in ADHD, it can complicate identification and diagnosis. So you need to keep that in mind, that there might be more going on here when you're seeing your patients with comorbid conditions. Non-response to ADHD treatment should prompt a reevaluation of ADHD diagnosis and evaluation for comorbidities, but vice versa. If you're treating something else, reevaluate for ADHD as well. And in the face of comorbidities, it's generally preferable to stabilize the most severe condition first, with the caveat that bipolar disorder, you always want to have the mood stabilizer on board before you start treating ADHD. And then treating the pharmacological and psychological options, and encourage cardiovascular exercise as able. That's my mantra for treating ADHD as well as the comorbidities. With that, I would like to thank you for your attention, and we will be opening up for questions after. Thank you.